And it took me 18 months to realize like I'm not getting better. And I had just and I collapsed basically. And at that point I went on a short-term disability. And unfortunately, right after short-term disability, I was hoping to only be on it for a couple months. I got reinfected and I ended up in the hospital with pneumonia, and it really deteriorated my baseline. And I'm still recovering from that, a year later. And right now, I'm 32, I spent my entire 30s with this condition. I can do about one or two things a day right now. Like I can do this and maybe one more thing, and that's basically all the productivity I can do in a day.
Hello and welcome to Cure Talks. Today we are exploring long COVID, a condition that is puzzling the minds of researchers, clinicians, patients, and caregivers alike. I'm Shweta Mishra, and today we have with us Dr. Benjamin Abramoff from the University of Pennsylvania. Dr. Abramoff is director of the Post-COVID Assessment and Recovery Clinic and the Spinal Cord Injury Program, and assistant professor of clinical physical medicine and rehabilitation at the University of Pennsylvania. Joining us on the panel is patient advocate Charlie McCone, a previously active 32-year-old who has been dealing with long COVID symptoms since last 2 years now and is committed to spreading awareness through his writings and media interviews. Welcome to Cure Talks, everyone.
Thanks for having me.
Thank you, Doc. Pleasure is all ours. Dr. Abramoff, it's more than 2 years now that we have been hearing stories about folks who were walking miles and miles a day, but are now being pushed in a wheelchair, and about folks who have never had any heart issues, but are all of a sudden dealing with congestive heart failures, and folks experiencing a variety of confusing symptoms, about more than 200 symptoms that is linked to this condition. So it's all very confusing. So what are we dealing with here? And can you please break it down for us? How is long COVID defined clinically? And what is the likelihood of someone developing the condition after a primary infection with COVID-19?
Yeah, so long COVID is really a pretty broad general term. And it really, for many of the definitions, includes patients who are critically ill in the hospital with COVID, in the ICU, sometimes on ECMO, all the way to patients who had mild initial courses, maybe even didn't even realize they were that sick, who continue to have lingering symptoms, oftentimes lasting months and months after infection. Now, the WHO has a definition that's become pretty commonly used and is one that is gaining traction clinically, that individuals with long COVID have symptoms for at least 3 months from the time of their initial infection, those symptoms lasting about 2 months and cannot be explained by any other reasons for having those symptoms. And the symptoms are broad. Some patients have fatigue prominent symptoms. Some people have cognitively prominent symptoms. Some patients have symptoms of pain, myalgia, muscle pain, joint pain. It's a wide spectrum of different symptoms. Now, what are the chances of having it? It's hard to say because studies look at this very differently. The best studies, the prospective studies, estimate somewhere between a 10, maybe to 30% chance of having ongoing symptoms following initial COVID infection. Luckily, over time, that rate seems to be going down with subsequent waves of Omicron compared to Delta, compared to Alpha. Although even with very small percentages, with a large wave like the Omicron wave, those numbers can still be very, very high.
Right. I know. Thank you, Doctor. We know research is going on worldwide, and there's a constant flow of new information about the incidence, diagnosis, and management of long COVID. And we may not have all the answers, but talking about diagnosis, how are patients being assessed right now for long COVID, and what diagnostic tests are being advised?
So there's a couple things to think about. As of now, we don't have a clinical biomarker, clinical test that says, right, you have a score of 15 on your long COVID blood test, so you have long COVID, and you have a score of 1, so you don't have long COVID. Now, there are studies and investigations into potential biomarkers that can be a sign that patients are more or less likely to have long COVID, but there's no one test or one study that we know of yet that will tell us if somebody has long COVID. Right now, it's really a clinical diagnosis. So based on what symptoms they're having, how long they're having those symptoms, and as part of this, we always look for any other underlying conditions or diseases that may be explaining their symptoms that are directly treatable. And we'll probably talk a little bit more about kind of what are the options of treatments for long COVID a little bit later. But at this point, we want to rule out other things that may be contributing to their symptoms. And if clinically we've ruled those things out and they have symptoms that are consistent with long COVID, patients will gain a diagnosis of long COVID.
Right. Thank you. Thanks. That's a useful bit of information, Doctor. I know we have dealt with several variants, like you just mentioned, variants of coronavirus over the past 2 years. Are there different types of long COVID depending on the coronavirus variants that cause the COVID-19 infection on the first hand? Do we know yet that how the symptoms change based on the variants?
So I think the bigger issue, the bigger question, the bigger dichotomy is not necessarily between variants, but severity. So it does seem that patients who are hospitalized or in the ICU have somewhat of a different clinical picture than those patients that were more mildly affected at home. And so patients, and we've known this for a long time, patients who are in the ICU or critically ill can develop a syndrome known as post-ICU syndrome. And that looks often very different than the patients who have the more mild illness. Now, there may be subtle changes over time. For example, smell and taste loss seems to be very much less prominent with subsequent waves than it was early on. And I'm seeing a lot less of that in clinic and talking to my clinical partners. But that's not a major evolution over time. And we're not really seeing, in terms of things like fatigue and the brain fog, some of these other very prominent symptoms, much of a change over time.
Right. Thank you. Thank you for sharing that, Doctor. Moving on to talking about some of the treatments currently available for long COVID. And we are seeing a lot of disparate answers to questions like these. And it's understandable given the complexity of the condition. But would be great if you could share what we have learned so far. What is working optimally for most long COVID patients in terms of treatment?
Yeah. So unfortunately, and this is one of the things that as a research community we're working on, for most of the symptoms, we're still treating it symptom-based and palliative. So we think about how do we make you feel better? So if you're fatigued, if you're not sleeping, do we give you medicine to make you sleep better? Or do we give you a neurostimulant to help you be more awake during the day? But ultimately, those types of symptomatic treatments are not what most of my patients are looking for. What my patients really want is something that will attack the root pathophysiologic causes of long COVID. And that is something that we're still looking at and exploring. So as of now, we have developed programs that do comprehensive rehabilitation, cognitive rehabilitation for things like brain fog. So again, sometimes medications for symptoms that patients are having. Sometimes things like diet and exercise and pacing and lifestyle adjustments can make a difference. But it's really on a case-by-case basis based on what the patient is presenting with.
Right. Thank you. Good to know that, Doctor. Let's talk about some of the initiatives that are going on to tackle long COVID. And I know the NIH created the Researching COVID to Enhance Recovery initiative that supports many researchers studying long COVID. And under this initiative, Penn Medicine is recruiting pregnant people with or without COVID, those who have been pregnant between 2020 and now. Could you please talk about that study and a little more on other ongoing initiatives at Penn?
Yeah, so the NIH study is a national research study funded by the NIH. It was given, I believe, $470 million. So it's an extremely large study to investigate the root causes and potential treatments of long COVID. Today, they've recruited thousands of patients, and their kind of first step has been looking at the history, the etiology, the pathophysiologic mechanisms. But the goal, and hopefully with time, that study will transition to be more looking at clinical trials, which I believe are kind of in their infancy and beginning to start soon, but haven't really come from that study yet. But beyond that, there's lots of national efforts, and that RECOVER study is not going to be the only answer to this. It's going to take research at all levels, from the basic science to the bedside, to really find the best treatments for long COVID. And even at Penn Medicine, I'm working with a group looking at autoimmunity and autoimmune factors as part of the pathophysiology of long COVID. There's a group that I also peripherally work with looking at the metabolomics, and that's just here at Penn. And there's many other studies looking at different treatment regimens out there, some of which have low levels of evidence, some which are starting to develop an evidence base. But certainly much more effort is needed on kind of all fronts in tackling long COVID.
Absolutely. Yeah. Yep. Thank you, Doctor. With that, I would now like to invite Charlie to the discussion. And Charlie, before you go ahead and ask your questions to Dr. Abramoff, would you like to share your experiences with long COVID? I know you were a very active person before you contracted the disease in March 2020, a couple of years back.
Sure. Yeah. First of all, thank you for having me, and thank you, Dr. Abramoff, for sharing your time as well. Yeah, I got sick. Right, I just turned 30 years old in March 2020 on the first wave. I was a, quote unquote, picture of health, kind of young, working professional. I had gotten sick. I was coming back from a biweekly, 3-mile run I do, and I'd got home that night, and all of a sudden I had a weird pain in my chest. And the next day, I was palpably short of breath for the first time in my life. And then I was basically just laid out for 10 days. And then by the third week, thought I was kind of getting better, but was starting to think, this is kind of lingering, pretty long. First, I had never been out sick more than a few days in my life. So the fact that I was still feeling run down into the third week was already sort of strange. Fourth week, thought I was kind of like getting over it. And by the end of the fourth week, I was like, okay, I don't think I have any symptoms. I'm going to go for a bike ride. Yeah. And at the end of that bike ride, I came back and I just collapsed. All my symptoms came rushing back. And that was the first time I had, the typical long COVID relapse, which is kind of the hallmark symptom of people who are experiencing this disease, is they have symptoms and then they kind of go away for a little bit, then they exert themselves, and then everything comes back. And it's kind of this, Prometheus rock type of, world we've been living in. And then throughout that process, on the 8th, I had similar experiences. By the 8th week, I thought I was getting better, but then all of a sudden I woke up one day and I had muscle twitching and peripheral neuropathy in my hands everywhere. And this was 2 months into this. And I was like, is this from the infection, or do I have some weird disease? And it was around that time that I had, gone online. And at that point, I thought, I was I had some terminal cancer or something like that. I had no idea that there was the concept of a post-infectious illness even existed. And then I found a support group online, and there was just thousands of posts of people my age saying, hey, it's been 8 weeks. I'm still really short of breath, yada, yada. And so that has been my worst symptom, is shortness of breath. I've had it now for 2.5 years. It feels like there's an anvil on your chest. It's incredibly uncomfortable. And it's very debilitating. And by the third month, again, I thought I was getting better, thought I was turning a corner. And then one day I woke up, I had a sharp left chest pain in my chest. And then I walked to the kitchen, my heart rate was 140. Oh. And then at that point, I had a pretty extensive workup, and they discovered I had a pericardial effusion, which is an inflammation of the heart sac. They thought I had myocarditis, but that was ruled out. Mm-hmm. And at that point, it was suspected maybe some mild pericarditis or something like that. And I was subsequently diagnosed with POTS, which is, an autonomic nervous system disorder. Whenever I, go upright, mm-hmm. my heart rate races, my blood pressure jumps. And that's a pretty common, symptom or consequence for a lot of long COVID patients. About 67% or something like are developing some sort of autonomic service dysfunction. Right. And so I tried to work through symptoms the first 1.5 years. I was completely housebound, and I could get through the workday, and then I would just collapse. and I just couldn't do anything else. And that's pretty typical for long COVID patients, is that they feel like the answer is, a week away, or the next specialist away, or the next month away, because, it's instilled in themselves that they're sick and they're just going to get better. And it took me 18 months to realize, like, I'm not getting better. And I had just, and I collapsed basically. And at that point I went on a short-term disability. And unfortunately, right after short-term disability, I was hoping to only be on it for a couple months. I got reinfected, and I ended up in the hospital with pneumonia, and it really deteriorated my baseline. And I'm still recovering from that, a year later. And right now, I'm 32. I spent my entire 30s with this condition. I can do about 1 or 2 things a day right now. Like, I can do this and maybe one more thing, and that's basically all the productivity I can do in a day. I have to rely on my
Right.
partner for full-time caretaker. So I'm not really independent. I can't really work right now. My symptoms are still very severe cardiorespiratory symptoms. There's still not a good answer to why long COVID patients have this, respiratory, dyspnea. It's kind of one of the main, a lot of the main investigations look normal, but there is some research that's coming out that's really interesting around that, I think.
Mhm.
But not a lot of answers. But I have a great team of doctors. They believe me, they support me, but it's just, it's incredibly challenging and
Right.
debilitating condition.
I think, Charlie, your story is, if I had to give a typical case of somebody with severe long COVID symptoms and severe long haul, I would say that it's very common, and there's thousands, if not hundreds of thousands of people out there with similar stories to Charlie's.
Right. Thank you for sharing your story, Charlie. And the fact that you are here despite your difficult symptoms is really commendable. Thank you so much for that. And thanks for your advocacy. Please go ahead with your questions for Dr. Abramoff now.
Sure. Yeah, my first question, Dr. Moff, is, so it seems like there is kind of like a mess of promising information out there. And I'm particularly interested in, are there any conversations happening in your world between long COVID clinics? Because now it seems like there are respective long COVID clinics with respective treatments. Stanford, I saw them, and they're saying 50% of our patients improve with low-dose naltrexone. Then you'll hear Dr. Petrino say about a lot of 70% of our patients get better with autonomic conditioning. And then you'll hear the Montana clinic say 90% of our patients are improving with nebulized budesonide, but it doesn't work with regular inhalers or regular prednisone. It has to be nebulized. And so it seems like there's a lot of promising anecdotal case studies that maybe warrant further investigation. And I'm wondering, are there conversations happening, or is there some type of plan to try and standardize, treatment? Because there are a few long COVID clinics that just don't feel like they're really doing anything. But there are some that feel like they have some things that are working. And I was wondering if you could just elaborate upon what might be happening behind the scenes, or what you think should happen if nothing is.
Yeah, so the main place that I think that is happening is the American Academy of Physical Medicine and Rehabilitation has a long COVID clinic collaborative. It's made up of about 36 clinics around the country. And that also includes patient advocates as part of that effort. And it's a forum that has developed some guidance statements on long COVID. Again, those tend to be a little bit more on the conservative side, just in the interest of safety. But there's a lot of discussion that happens at that level. And then there's also many kind of smaller research pockets of conversations happening, maybe not on the clinical treatment side, but certainly on the kind of basic science pathophysiology side. And that's happening between many different institutions. But I do think that there needs to be more discussions of this. And beyond that, there needs to be clinical trials. So if things are really working, whether that's low-dose naltrexone, which does definitely work with some patients, or that's physical therapy and different physical therapy protocols, which certainly works with some patients, those trials need to really happen so that we have concrete evidence. And I want to personally see more from the NIH of the funding that's out there going to these studies that are really looking at clinical trials, because that's the only way we're going to get answers. And I hope that this focus, as important as understanding the pathophysiology is, so we can get to that cure idea, which is what everybody wants, we also need to do treatments to make people feel better right now, and we need to spread those, and we have to know it works.
Great. So yeah, that makes sense. I mean, nobody's going to say like this works until there's there's evidence to say that. Is there any type of like funnel that's happening that you're aware of, like, hey, this is working, this person said this is working, let's pitch this for a clinical trial? Or is it just like contingent upon the fact whether a researcher is or a physician acts to be plugged into research and they're kind of have that network? I guess I just a little bit concerned that there's going to be these treatments that are promising that never make it, cross, or up the stream to clinical trial. And I'm wondering, is that just kind of luck of the draw, or it just depends how ambitious or adamant, the respective physician, or respective group is, et cetera.
Yeah, no, I hear definitely where that concern is coming from. I think that as of now, a lot of it is kind of one-off clinics and clinical folks who have something that works or they think might work, and then they do a trial for it. And I don't think there's a national network of clinical trials, and hopefully the Recover Project will kind of incorporate that a little bit more to what they do as they kind of move forward. It's always slow when you're kind of going through this big, huge bureaucracy of something like the Recover trial. I would love to see some sort of clinical network of clinical trials for multi-centered large clinical trials that really build that support to get some of these things that are promising
That's interesting.
into the kind of regular person's hands. It's going to take funding, to be honest with you, which I don't think we've seen for that type of effort yet. And again, even at that level, you need to have some sort of early data that supports it before going to kind of the larger scale multi-centered clinical trials.
Got it. Yeah. Okay. Yeah, that kind of goes into my next question, and is kind of from your vantage point as somebody who's treating long COVID patients, what do you see as kind of your current immediate biggest barrier to improving, the quality of care for these folks? I think maybe the most obvious answer would be clear-cut clinical trials, so you could have, treatments. But I've heard some doctors say, like, I'm spending way too much time fighting insurance because they're not holding up their end of the bargain, or I'm not getting compensated for doing all this disability paperwork and longer consultations, or there's just my colleagues aren't educated enough and they're kind of, causing more issues with me. I'm telling them to do one thing and I'm getting another thing. So I guess your last point is I find to be interesting as well. But is there anything that kind of repeatedly comes up to you as like, I really need this taken care of or off my plate?
Yeah, I mean, I think there's the ultimate barriers again is kind of not understanding the root causes. So a clinician, it's kind of in the nature of a lot of clinicians is they want answers and they want to be able to say, hey, you have hypertension. Well, I know the hypertension medicines that work. Take A, then take B, then take C. And living in kind of this milieu of uncertainty is challenging for many clinicians out there. And also, kind of to your other point, certainly, to do, what we do here in our clinic and many of our, the academic centers that are hosting post-COVID clinics or long COVID clinics would be very challenging to do in an environment that like a private clinic or a private practice or a smaller clinic where you don't have the resources of a major institution, because there definitely are lots of disability issues that come into play, insurance issues that can come into play at times, and it can be challenging to get consultants sometimes to see these patients if you're not in the right setting. And I've heard of clinics that have shut down because they couldn't get those resources in place. So certainly those are barriers. There are clinics out there that are doing it, and I really applaud them, who are really putting in the time and effort, but it is definitely challenging. And I think, to your last point, there definitely also needs to be more education of clinicians out there. I think it's definitely changed over time. When I first was seeing patients in June of 2020, the percentage of patients that said they were getting gaslit and it was all in their head and it's not real symptoms was like really 95% 50% plus. Now it's a very small number, and it's usually one clinician that they can come to that kind of dismisses them. Most clinicians now, I think, recognize this as a real entity, which I think is a real big, actually positive step in the right direction. But certainly that doesn't necessarily lead to them knowing kind of the ideal clinical care. And at the same time, part of that is because we don't know the ideal clinical care. So these things are all really tied together to one another.
Yeah, I guess what I was trying to get at is that in the advocacy community right now, in the patient advocacy community, there's a lot of varying different opinions around what's the biggest priority. And I was just kind of curious from a physician's point, what do you see is that, and that kind of seems to land on, we just need clinical trials. And that's the best, bang for our advocacy buck is pushing for that. What do you think is the right framework to kind of, meet patients where they are, take some of the emerging evidence, into consideration, look at some of these case studies as, what do you think is the right approach as a physician trying to help patients right now? I think there's a lot of varying opinions around we shouldn't do anything until there is a randomized controlled trial. And I think there are some physicians saying, hey, this is, a low risk drug. It looks like it's helped 20 patients, it helped another one patient, let's give it a go. What do you think is the right approach to that?
Yeah, I think that's a really challenging and complex question, because I don't think there's a single threshold or line. I think you kind of have to weigh different aspects of it, weigh different pieces. You have to weigh what's the risks, what's the benefit, what's the level of evidence where it does exist. What's the cost? There are people out there who are trying to make a lot of money, and there is a psychological reaction. If you spend a lot of money on a treatment, the chances of having a beneficial effect go up. So
really?
A lot of pieces, and there's also the element of what are you hearing from your colleagues? What have worked anecdotally in your experience? How severe is the patient's symptoms? What have they tried in the past? I'm not against all treatments that haven't gone through double-blind placebo-controlled studies, and we prescribe those fairly routinely. But I always start with the things that are simple, that work, that are 100% safe or 95% safe, before we jump to the things that are more experimental or have risks of side effects. And then there's some things that honestly have had poor evidence, that have they're so not well done, and patients will bring to me and say, hey, I saw this study and I look at the primary data and I'm really not convinced by it, and the risks are pretty significant of taking those drugs, let's say, and that's where some of this conflict between patients and clinicians can come in. So I think that's where having these conversations, because that conflict has been there at the get-go sometimes, but when you have a conversation of why I prefer this treatment over that treatment, and this is where my threshold lies, I've had very, very few negative interactions at the end of the day, or where patients really felt like, hey, I'm being ignored. I think part of it is just taking this patient's symptoms seriously and having somewhat of a plan and a path forward.
Anecdotally, have you had success with some off-label drugs and treatments that have kind of raised your eyebrows and you're like, I want to see the data on this? I guess, are there 2-3 drugs or therapies that you find to be reliable first line defense for patients you're seeing?
Yeah, so I don't think there's really been anything that's been, to me, like a light bulb and saying this is it. This is the treatment that's going to work for everyone. I think, one thing that we always do is, and what works best a lot of the time, is treating the underlying comorbidities, whether that's insomnia, whether that's pain, whether that's fatigue, by treating those comorbidities kind of in turn, patients often feel better. I think, proper therapy is really important. So doing it in the right way, whether that's addressing the dysautonomia, whether that's addressing the brain fog with cognitive retraining, those things can also be very effective. Now, off-label medications, I don't know if this is the right forum to kind of go into recommending one over another, but I think they can certainly be considered. You mentioned low dose naltrexone for some patients. That's a reasonable option. Duloxetine or SNRI medicines can be helpful for patients with neuropathic pain, with sometimes with energy issues. Sometimes we have medications that can help with pain and sleep. So it's just really on a case-by-case basis and what symptoms their patient is experiencing.
How far away do you think we are from long COVID clinics having like a standard of care, treatment? Like we know like this, like where maybe 80%, 70% of long COVID clinics are doing the same thing and they're reliably helping patients get better.
I think we're still somewhat far away. I think we're probably not within a year of that happening. Maybe 2 years would be my just off the cuff estimate. But I think there's still going to be a lot of time before we get that kind of cookie cutter approach. But I'm also very hopeful and optimistic, and maybe this is a false optimism, that we'll be able to find some medications that really help with the underlying causes of long COVID, or are more targeted to the underlying causes. Because even medications like low dose naltrexone, my gut impression is it's more of a symptomatic treatment and not a root cause treatment.
Yeah. Thank you for that. I guess one kind of more granular question I have is, do you think long COVID has kind of highlighted or exemplified some kind of problems with the current, medical structure approach? Or do you think it's just that it's a new disease and the system is fine and it just needs to wait for the science to catch up?
So I guess off the bat, I think everybody's frustrated by the pace of this and the pace of research. And I think, it's always been the case. Research, and especially government funded research, is very slow. That's where things like you're doing as an advocate can really come in, is if you with private foundations and things like that, or if there was a long COVID foundation that really had substantial funding, and that was kind of the root cause, the root home of some of that. I think some of this research could be maybe moved a little bit faster. And I do think there's other fundamental issues in terms of providing complex care and reimbursement for that, and the social resources for social work or for clinical coordinators that is needed in many conditions. And I think long COVID does exemplify some of those issues that I think if resources were focused for some of these chronic diseases, it would help in multidisciplinary care. It would help with clinical care as well.
So you mentioned earlier that, around in June, the first summer, around 90% of patients were kind of not being believed. And now that has increased a lot. What are you seeing in your world around people's perception of long COVID? I think, patients are obviously, we see it, I see it improving, but a lot of patients, I have friends still reaching out saying my doctors, they don't think there's anything wrong with me. I have all these things. So it just seems like there is still some either lack of education or still some suspicion around what it is. And I guess what one frustration long COVID patients have is like, we need clinical trials now. We need all of this advocacy now. We would love to see, the physician and clinical community rally around that need for long COVID treatments the same way they did around how everybody should get their vaccines.
Yeah, I think there's a couple of things here. One, like I mentioned kind of before, I think it is getting better on that front, but I do think that it's still an issue. And I think sometimes when a clinician says there's nothing wrong with you, what they're really reflecting is, hey, we did all this testing. We did a chest x-ray, we did a chest CT scan, we did a cardiac echo, and all of that came back normal. So you're not having, there's nothing I can do for you. Charlie, you don't really have anything wrong with you, even though these tests, even though you're sitting there saying there is something wrong with me. And I think that really, it speaks to kind of a lack of maybe understanding some of the more investigative clinical research that's being done that still can show abnormalities even when normal testing is showing kind of no abnormalities. And people forget that even something that may be normal for you in the normal range might not be your normal. And so even though you can walk on a treadmill for 10 minutes and that's within normal limits, as an athlete who was doing 3-mile runs before, that might be significantly different for you. So I think there's a few components of sometimes when a clinician is saying, hey, we don't know what's going on, or there's nothing wrong with you, it's that there's nothing wrong with you on our objective testing that's, we've had for years and years and years. I also think that that this also speaks to some of the complexity of it. And so when issues are complex and there's not one thing like a vaccine to kind of rally around, it makes what is the advocacy efforts that much more challenging. And so I agree. I think there should be more funding, and I try to advocate as best I can for more clinical care. But I think sometimes many of the clinicians don't know exactly what they're even asking for and how they would ask for it.
Yeah, I think that's the issue that I'm getting at, is that it's like, I sympathize. The first year, all my doctors, luckily, most of them believed me. They're like, look, dude, I don't know what to do. I believe you. I want to help you. I just don't have any other tools at my disposal. And I sympathized with them. And my question is that you're like, well, we need more clinical trials. Is that, the issue is that the physicians don't know what clinical trials to advocate for, or I guess my thinking is like, well, I would imagine then there'd be more pressure from the medical community on, the research and, government community, be like, hey, like we need tools here. Like, you guys got to keep up to speed, because I got all these patients. I can't do anything from them until you guys help me out here. And I feel like there is that sometimes, I feel like there could be a little bit more of that, to put it, lightly.
Right. Yeah. Thank you, Charlie. Great questions and great discussion between the two of you. I'm afraid we are running out of time. So I just have one more question before we wrap up the show today. Doctor, do you have any advice for recovery from long COVID patients? Any exercises that you recommend, or any food supplements that you see are working for patients?
Yeah, I think a lot of time this is such a complex question, because it's very different for each individual, how severe their symptoms are, where they are in the recovery process. I would say, my general advice for somebody who has long COVID, or who has who had COVID and just not getting over it, the first thing, the kind of the early acute period, is not to push things going back, to make sure you're resting, to listen to your body as you're recovering in those first weeks to months after infection. I think getting a close clinical relationship with your PCP and following up with them, even if you think you're on the road to recovery, just to keep them in the loop in case things don't go in the right direction, is a key step of this too. And then the other thing is, if you can get it established, I know it's very difficult and there's long wait times, but if you can get established with a long COVID clinic, sometimes they can give you resources that can be very helpful.
Right. Thank you. Thank you, Doctor. Charlie, quick advice for your fellow long haulers.
Yeah, I mean, there are things that can help and treat, especially if you can get a diagnosis. Like, my mom reached out to me yesterday and she says, my friend, she went to a cardiologist and she said her heart's fine, but every time she stands up, it goes to 130. I'm like, that's POTS, and that's actually treatable. Or there are medications that can help with that. And then, to me, that's one of the biggest things that I feel like there's a need for just more clinical education on, is that's something patients will present with, that if they're referred to a physician with the right understanding of that, can actually improve their quality of life.
Right.
It's not going to necessarily improve their underlying cause, but that's something that has helped me. And so I would say, just stay persistent. Make sure you find a physician who, if they don't know what to do, at least they're dedicated to help finding the right team for you. And yeah, because there are things that can help.
Thank you. Yeah, great advice. Great advice, Charlie. Thank you, Dr. Abramoff. Very helpful advice. And with that, I think it's time to wrap up today's show. Thank you very much for such an informative session and addressing all our queries on long COVID. Charlie, thanks for agreeing to join us today despite your condition, and guiding the panel with your very thoughtful questions. We also thank the University of Pennsylvania, and this talk will be made available on curetalks.com. Until we meet next time, thank you everyone, and have a great day.
Thank you.
Thank you.